G'day everyone, Simon Ashwell here. This is Health Highlights. Health Highlights is a show about health professionals, and the people and the stories behind the names that we hear about, but we seldom get to meet. And today, there's quite a few hot topics at the moment in our community around pain management and drug usage. And we actually have the great privilege and honour of having Chris Hayes join us. Thanks for joining us, Chris.
Thank you, Simon. Good morning.
Chris, you have got a list of things that you actually do. So Chris was the founder of HIPS at the John Hunt Hospital, which is the Hunter Integrated Pain Service, and you founded that in 1997.
That's right.
And you're still the director of that today?
Yes.
Yes. He's also the dean of all of the pain specialties throughout Australia. So you head up the association, is that right?
The Faculty of Pain Medicine it is called, which is part of the Australian New Zealand College of Anaesthetists.
Okay, wonderful. And also, on top of that, you've actually formulated a assessment tool, which is called Epoch. Just quickly explain what that is.
So Epoch is a shared work with the University of Wollongong, Professor Kathy Eager there. So it's a way of measuring outcomes across all the pain services in Australia and New Zealand, or at least 80 of them have enrolled in that.
Wonderful, wow.
And so we compare our outcomes one against the other.
And so it's like a standardised tool that allows everyone to be able to assess pain.
Exactly.
Wow. So it's a great honour to have Chris actually with us today, and he's going to share and give us his thoughts around some of these really hot topics at the moment that we've got coming on in our community. Okay, so Chris, can you firstly tell us, how did you come to be a pain specialist?
It goes back a while now, Simon. Two stories sprung to mind. The first was my wife's obstetric experience. We were in New Zealand at the time and she was having a difficult first delivery. The obstetrician was somewhat detached from her experience, and the anaesthetist came in and was the hero of the piece. He sat down, introduced himself and took away her pain in the midst of an otherwise distressing situation. So that was fairly pivotal in my decision to do anaesthetics. And then also very interested back at that time in various healing traditions through Christian circles and other circles, looking at the kind of deeper healing modalities, and pain often came up in those settings. So the exploration of mind, body, spirit, whatever we mean by those things, and deeper answers to our health problems was very much in my mind.
Okay, wonderful. So on the pain, in 2016, you wrote a piece in the Herald, which was quite an interesting piece, where you basically said that the medical fraternity had got it wrong, that they needed to do a turnaround on the use of opioids, and you actually publicly apologised on behalf of doctors for the use of this medication. So what led to you actually making that public declaration?
A lot of it comes down to the basic scientific evidence, and I guess part of our medical job is to interpret, explain what's happening in the scientific evidence. So we do know that the morphine group of drugs, the opioids, work well for short-term pain or acute pain. They work well at the end of life if someone's dying of cancer, but the evidence was coming through scientifically, and also in our own experience in the pain clinic, that these drugs work poorly over the long term, so for chronic non-cancer pain. So really it was a statement of that 20 years or so earlier we'd been overly optimistic based on how well these drugs work in the short term. We'd extrapolated to the long term, but as the evidence came in, we were finding that they just didn't work. So hence the need for an about turn. And I do think if we make mistakes, even unintentional mistakes, it is a polite thing, and it's also a healing thing for the community to admit that we've played a part in getting that wrong. So I think it is useful for us to say medically, sorry, we were not trying to lead people astray, we were not trying to give people unhelpful treatments, but in fact we did that, we're sorry.
Wow, I mean it's a big move really, and it's certainly not something that admission of fault in some ways is what people would say when you actually say sorry. So firstly, how was it received by the medical community? And then secondly, how was it received by the general public?
I think a mixed reception by the medical community and a strong endorsement by the general public. Within the medical community, there are those who recognise the truth behind that and they endorse it. On the other hand, there may be those who feel a bit conflicted by statements coming out like that, and particularly if they have been investing a lot of years of practice in prescribing opioids for long-term pain. Change is hard for any human beings, and I think for them to do a turnaround may perhaps in some cases take a little longer.
Yep.
But the general public broadly were very understanding, and I've only received feedback of gratitude and thanks for being bold enough to speak out in that way from the public.
Absolutely, it is such a bold move. And so 2 years on now, looking back, it was April 2016, wasn't it? So nearly 2 years. What have you seen as the response and even the outcome of, say, that in the clients? Has there been healing? Have you seen a change?
I think it is changing, but slowly. We're certainly seeing fewer people coming into our pain service HIPS at the John Hunter Hospital on the really high doses of opioids, and we have seen amongst some, at any rate, a greater early openness to coming down on that medication. You mentioned the Epoch, our outcomes system, before, and we're looking at outcomes across all the pain services who are engaged in Epoch in Australia and New Zealand, and people being treated at those pain services are consistently dropping down on their opioid doses. We see that. However, on the other hand, if you look at the Medicare data of what's happening across the broader community of patients out there, opioid prescription is still going up in Australia.
Right. So
we're not there yet.
Yes, absolutely. Well, that leads us to probably the other big topic around at the moment is the actual codeine is becoming a prescription drug. And so therefore you can't just get it off the shelf. So can you maybe tell us a little bit about behind the reasoning for that, and what do you think that will be a benefit to the chronic pain in our community?
I think it's largely come out of a concern for safety in the community. There have been a rising rate of deaths related to codeine use, and in some people that's directly related to codeine, so those whose body rapidly converts it to morphine. It is normally converted to morphine, but if you're a rapid metabolizer, as we say, you get higher levels of morphine in your body after codeine use, and that can put you at risk, particularly if you're frail and elderly. That's one aspect. The other death-related aspect is if people do become addicted to the codeine and take a lot of that over-the-counter medication, often it is combined with an anti-inflammatory or paracetamol, and therefore that person may get a toxic dose of either of those agents, and the death comes from perhaps bleeding from a stomach ulcer, a side effect of the anti-inflammatory, or liver damage from the paracetamol. So there is harm there. We know that there are a substantial number of people out there who are addicted or dependent, as one would say, on codeine, and so that's really the reasoning why it's going to medical only prescription, feeling like pharmacies can do certain protective things, but generally they're not well set up to have conversations about difficult addiction related issues at the front counter.
Well, that's great. And so then the third topic, because it's all very interesting at the moment, is around cannabis and the actual legalisation of cannabis. I know particularly with you being the Dean of the Pain of Australia, or the facility at least, there's been a lot of discussion around that, and I think you've been quite open about what that stance looks like.
Yes.
Can you give us a little bit of background onto the reason why they want cannabis legalised, and what is your opinion on that?
That is a big question.
It is.
Simon, I think I have been reflecting quite a bit about this in our society generally, and it's something of a debate around rights as human beings alongside of responsibilities, and I guess in our societies across the developed world we seem to be in more of a mind to back people's rights at the moment, give people what they want. It's my right to access this or that. I'm concerned about that, again, from the community safety point of view, and I think it may not necessarily be always good to give people what they want at first pass. Perhaps people have a greater responsibility to contribute to society. So that's the background. So the push in regard to cannabis has come mainly from community advocacy, perhaps from industry who are involved in cultivation and manufacture of cannabis, and then the political push as well. The push down that road hasn't come from medical circles at all.
So is there medical evidence that it is helpful for some people, or is it really just there are some benefits?
There's very sparse evidence. In certain areas, like particular rare forms of epilepsy in children, there are some marginal benefits at the cost of side effects. Other than that, we're not really sure. It's really an open question in terms of the scientific evidence. At a conference I was at the other day, one of the speakers was summarising the evidence around chronic non-cancer pain, and it came out as they pulled all the scientific evidence around cannabis use that you need to treat 22 people before one person gets 30% pain reduction. So it's a very ineffective treatment for chronic non-cancer pain, and if we're talking long-term use, then people are exposed to risks, particularly to do with their mental health, so the risks of paranoia, the risks of demotivation and psychosis substantial.
So as a doctor, your recommendation is that, from what I'm hearing, is that cannabis is probably not the best option, and there's other ones that are better, particularly for their on other side effects and health benefits.
Yes, really at the moment I would suggest that if it is being used in chronic non-cancer pain, that should be as part of a research project only. We shouldn't have the relatively open access. That is the pathway they've gone down in the United States.
Okay. Well, look, I'm sure you found that extremely interesting. A lot of things to think about and consider from Chris. So thank you so much for joining us, Chris.
That's a pleasure, Simon.
And look, thank you for joining us. Look, next week we're going to continue on speaking to Chris. He's now going to elaborate in the next session about chronic pain and what that looks like at the John Hunter Hospital. So if you've been interested, join us at the same time, 12:30 on Wednesday. We look forward to seeing you then. Have a great week. Remember, healing is a gift, health a responsibility. See you next week.